Hi, everyone. Welcome. Grab a seat and get comfortable. You have just entered the Smartest Doctor in the Room podcast, where you can get the best information anytime, anywhere. I'm your host, Dr. Dean Mitchell. Today's podcast will be on the current treatment for dangerous food allergies in children. Food allergies is still a prevalent issue among our children here in the United States and in Western countries in general. There has been new research in recent years that have shown that early introduction of specific allergenic foods such as peanuts, tree nuts, milk can actually decrease the likelihood of a child developing a severe food allergy. This was from what's called the LEAP study. But in the meantime, we still have too many children with dangerous food allergies that are seeking protection, not just by avoidance, but through treatment. I'd like to take a moment to let my listeners know that my new book, Conquering Candida, is now available on Amazon in paperback and ebook. If you believe you suffer from Candida, this is the first book in 50 years since the original book, The Yeast Connection by Dr. William Crook, to give credence to this underdiagnosed and undertreated condition. If you also want to understand gut health and the microbiome, I also believe you will enjoy this book. I do appreciate if you read this book to rate it on Amazon and provide your comments and a review. My guest today, Dr. Moshe Ben-Shoshan, and I both have some things in common. We both studied medicine at Tel Aviv University back in the day. We both went on to specialize in allergy and immunology, and we both treat children with dangerous food allergies. Dr. Ben-Shoshan is an associate professor at McGill Medical University, Healthcare in Canada. Just for you folks that don't know, that's the Harvard of Canada. He also just recently had an article that I saw in my news feed about a pre-publication that really caught my eye, and we're going to discuss on possibly an even safer way to treat food allergies. So it's really my pleasure to welcome Dr. Moshe Ben-Shoshan to the podcast.
Hello, and thank you for having me.
Okay. So Dr. Ben-Shoshan, I want to ask you a couple of background questions. I always like to ask my guests this. So why did you choose allergy as a specialty? And I have to preface it with, where you come from in Israel, there aren't that many kids that have the food allergies like in the other countries. So, and the second part too is, why did you end up, if you don't mind telling me, why you ended up going to Canada for the rest of your training?
Sure. So allergy immunology in general in pediatrics does not have a specialist program for fellowship, at least when I was training in Dana Children's Hospital in Tel Aviv. And there was a need for it that was increasing, and there was awareness that the need is required. Hence, I applied for fellowships both in the US and in Canada. Canada, to be very honest, was more affordable regarding cost of living. So I think that was a major consideration when I made my choice. And also I had, I think, a very good interaction with my mentor at the time, which was Dr. Ann Clark and Dr. Rhoda Kagan. And they caught my attention because they were interested mainly in studying peanut allergy, and said, well, we almost never heard about peanut allergy in Canada. In Israel, everybody's eating that crap snack called bamba. Exactly. So it would be very interesting to study that and see why specifically there's an increase in the prevalence of peanut allergy and what are the factors associated with that, because you won't expect genetic background to change so fast over a decade to cause such an increase in the prevalence of peanut allergy. So it must be related to something in the environment or in the lifestyle that we can control and possibly, as the LEAP study has shown later on, reduce the risk of peanut allergy.
Yeah, I know it's interesting you mentioned that. Just for our listeners, this is so interesting because, for many, many years, if a parent had a child and like an older sibling that was very allergic with dangerous food allergies, they typically would think, oh gosh, I have to avoid this in my own house so my older child doesn't have a bad reaction. And then of course, I don't want my younger child to get that. And what was really fascinating is the internationally well-known Dr. Gideon Lack
in London. I remember reading the story, actually. It was really very fascinating how he was giving a lecture in Israel, and he must have been lecturing about food allergies. And he said, just out of curiosity, how many of the pediatricians here, have a lot of children with food allergies? And hardly any hands went up. And then he said to himself, this is strange. He said, I know there's a Jewish community in London, and I know I have some friends like Hugh Sampson. There's a Jewish community in New York. He goes, let's take a look and compare what is different about these essentially same genetic background, yet these two, quote, Western, sophisticated countries are having this problem and Israel is not. And as you well know, the answer seemed to come out to be that the peanut paste in Bamba, like the kind of infant snacks that they eat in Israel, seem to be giving protection to the Israeli children. And that set off his whole research into looking into early introduction, which is really against the grain thinking. And it's proved to be successful. I mean, from what I understand now, too, we're starting to see a decrease in food allergies, but still we're stuck with a lot of kids that have it. Question for you. Okay, now I'm really going to get right into it. For many years, children with dangerous food allergies had only one option, and that was avoidance. However, we all know, as practitioners, as parents, that's just not always possible. Children with these allergies and their parents have to be super vigilant, super cautious, not to have an accidental ingestion of a tree nut or peanut that could be in a cake or a cookie that could be life-threatening. But today we do have several options, which I feel like the public is still not fully aware of. So I'd like to review them with you and discuss a little bit from your expertise, and I'll give my insight as well, since this is also my specialty, the pros and cons of each treatment, if we could. So Dr. Ben-Shoshan, oral immunotherapy, which again, for our listeners, just so if you're not familiar with, is when a child that has potentially a dangerous food allergy is given actually like in a powder, the actual peanut protein, starting at low doses, but they tend to go up to fairly high doses. This has been around for about 10 years, and it has been incredibly successful in desensitizing many children. It takes weeks and months to get up to the high levels, typically about 300 milligrams, equivalent to one peanut, or some of them go even higher. But as Dr. Ben-Shoshan, I think, knows, and I know, I mean, I was never the biggest advocate for it because there's a lot of reactions, when these kids, and they have to be there for hours. So tell me a little bit your experience with OIT, because again, this gets into your article we'll be discussing.
Right. So as you mentioned, in the past, it was just avoidance, but especially for certain foods like milk and egg, it's very hard to avoid, even if you're vigilant, and there are like 40% annual reactions accidentally or inadvertently due to the exposure to this food, even in places that declare that they are allergen-free, right? So there was the studies from the UK showing that when you sell in a bakery a pastry that is considered to be milk-free, often it contains milk. And we see these recalls of foods, dark chocolates that are supposed to be dairy-free that contains milk. And we need to remember that people with this allergy can react to very small doses, like 0.5 milligram even of milk protein. And just for your understanding, 1 ml of milk is about 35 to 40 milligram protein. So big risk. 2 sesame seeds is 1 milligram protein. So, a lot of risk for accidental exposure, even if you try to be vigilant. So we were very excited by the fact that in the last decade, as you mentioned, there was a new strategy that was put forward in order to desensitize children to food allergens. And it's important to understand that desensitization is not necessarily a cure. So in desensitization, you need to expose to the food in almost regular or daily fashion in order to protect the child from response. In cure or tolerance, true tolerance, the child might avoid the food for a month, 2 months, and nothing will happen with it when he's re-exposed.
My patients are always searching for credible alternatives to medications for their medical conditions. If you've been following the podcast, you may have seen I have had on top experts in the emerging field of vagal nerve stimulation. One of my guests, Dr. Dave Raven, did groundbreaking work with veterans at the Pittsburgh VA, showing that using vagal nerve stimulation, he could decrease the post-traumatic stress symptoms of these patients. He later founded a company called Apollo, which has a wristband device called Apollo Neuro that delivers gentle stimulation to the body to help treat conditions ranging from anxiety, depression, and even poor sleep. It has a special app to your phone that also has special programs for calm, unwind, and sleep. If you are looking for a drug-free way to get relief, you may want to try the Apollo Neuro device. Please see the link in our show notes or go to the Apollo website, but put in SMART-MD in the coupon space to get a 5% discount.
So for some children, the process of desensitization will be protective, but will not lead to cure. And as in the impact study, reported, almost 80% of children had relapse of their reactions once they stopped eating peanuts.
80%?
Very high, 80%, yeah.
Okay, so let me ask you this too, because I'm going to remind you of something fascinating that happened in Israel. But so typically, I believe with oral immunotherapy, the patients are doing it for at least 2 or 3 years, correct?
Well, they until they get to the high dose of the maintenance, and then they need to continue for life.
Oh, they do?
Yeah.
Well, back in the day, what I hear in the United States is that, like, again, and this is what's nice about your studies, that because a lot of the children got very tired of this, like, typically when they got to the maintenance dose, they were eating like 7 peanuts a day for life.
Yeah.
That gets to be very
consuming.
Annoying.
Yes.
Okay, so they can't really stop the maintenance dosing because we don't know when a permanent desensitization will be achieved.
Right. For some kids, they might be able to stop. So the study suggests, and more recent studies suggest that when you start very early, and for example, the level of IgE is not very high, there's no severe atopic dermatitis, then you might be able to be cured. So there was a recent study in JAK in practice showing that when you start before the age of 2 years old, and the kids actually start to love it and they go to high doses, you don't necessarily need to be that vigilant and continue to eat it every day. But it's very hard to predict who that group will be. The more recent study suggests that these are the groups that start very early and do not have a very severe reaction or very severe initial reaction to peanut. So to be on the cautious side, we need to explain to parents that for most kids, at least for now, until we have better ways to identify that one that will be cured, we need to continue for life. So it's not a walk in the park. And in order to make it more, practical, we tell parents at least 3 times a week.
Yeah.
The thing is that when they're getting to that path of cure, they actually love peanut and they want to eat more.
Really?
But for most kids,
it's funny. I would think, just again, for our listeners, it's like, it's such an emotional thing for something that, again, we're talking about dangerous reactions for kids to get over that mental bar to say, because I would think also like a lot of them, unfortunately, they just, whatever their taste buds, something maybe deep in their brain is like, this is really not great for me, but I'm doing it because I need to,
Yeah. Go ahead, sorry.
There was an amazing story in one of our journals. You probably know this, but I have to tell the listeners because it was mind-blowing. People are all aware, unfortunately, what happened in Israel with the hostages, which was horrible. But in one of our journals, there was a letter or comment to the editor that one of the Israeli doctors had a patient. He had been like a 7 or 8 year old boy that had severe peanut allergy, and he went through OIT, I think for about a year or 2 years, and I think he stopped it for a little while. I'm recollecting, and then unfortunately he was taken hostage during the horrible event on October 7th. And while he was in captivity, they were feeding him every day. Now, they called it a different kind of nut because they were giving them very little food, but it actually was peanut. And he would get a little bit of a tingling in his mouth, but he had no severe reaction all during those months that he was in captivity. So I had to say, well, that, God was looking out for him in
Yeah.
that situation, sort of. The other part I don't know about, but what's your thoughts on that?
Yeah, so probably he was in that lucky group that was more successful desensitized, and he had not need to maintain that level of vigilance in order to maintain the unresponsiveness to peanut. But it's very hard to predict who will be in that group.
Sure.
So we are, erring to the side of cautious now and telling them that don't think about it as a cure, but you need to continue and expose. And as you said, there was that case study showing that especially during the escalation phase or the build-up phase of peanut desensitization, you have 3 times more risk for anaphylaxis. And that's true also for other foods, including milk.
Right. So Dr. Ben-Shoshan, how do you advise a parent, about whether to undertake this? And also,
So the main
again, as you know, too,
yeah.
we're going to get into it in a second, too. And a lot of these children, it's not just one food. It's typically multiple foods that at least I'm seeing in my practice. And that also takes even more time, right? Because you can't really do multiple foods at once.
So actually, you can do multiple foods
Can
at
you?
once.
Yeah.
We do it, for example, in San Justine. We do it less because we want to know for each food how well it goes. But you could do it. There are studies that it works. But for me, the main factor will be the age. So first of all, the age. If it's a toddler, it's easier. Just think about it in other ways. I mean, it's easier to change the immune system when you're less mature, like
Right.
anything else in life. So when they're toddlers, ideally less than 2 years old, it's just so much easier. It's like almost a walk in the park.
Yeah.
And as I said, these toddlers love it. I mean, I have, the outlier, the toddler that does not agree with the desensitization, and some of them have got aversion.
Are these
so it's
children
really
presented
hard.
with very severe reactions? Because I know also too, sometimes it seems like the very young children, I guess they haven't been exposed enough. I mean, when you're getting one at that age, they may have hives like urticaria or maybe a little wheezing, but they don't go into anaphylaxis. I mean, are you having the kids that have anaphylaxis that you're desensitizing?
So we had some anaphylaxis, yes, and we do that. So I think it's not, but it usually works very well, even if they had anaphylaxis for peanut. The one that is the hardest to desensitize and has the higher likelihood of reaction is milk. Actually, not peanut. We all think about peanut and demonizing peanut, but milk is the hardest one. And if you look at fatality rate now in Canada, for example, and even in the UK in children with food allergy, it's mainly milk. So milk is a special problem, but even kids with anaphylaxis, when you start early enough, seems to be working very well. As long as you are cautious of the dose in which you start, usually it's about 5 to 10 milligram protein, and then you go slowly up. So it works well, and it's harder in the teenagers. So I think we need to find, and that brings me to our study, we need to find strategies that will make desensitization safer while still effective. And
I think I'll have an answer for that. We'll get that in a second.
Yeah.
I just want to ask you, in your journal, in your paper that's going to be published, which is, again, I want to get into a little bit because you go to a lower dose and achieve the same success.
Yeah.
I'm just curious, the children in this, that I don't remember, were they all very young or was it varied, the ages?
No, so our median age was around 10 years old. So this is usually targeting the more risky kids, the one that have a very well-established peanut allergy, and they had challenges and they're all reacted to small doses of peanut. So these are the most risky population.
And what was the youngest child, if you can recall, that was like a 1-year-old or just 2-year-old? I mean,
I would say that for that study, around 6 years old.
6 was the youngest. Okay.
Yeah.
Interesting. Okay.
Yeah.
Okay. So, and let me ask you this too, because really one of the key things that you found, which I thought was very exciting and kind of relates to something that I'll be talking about in a minute that I do. So you, I guess, decided, like, why don't we try a lower dose? Because I think there were earlier studies that they tried lower doses of peanut, I think, or maybe it was Xolair, I really don't remember, that it didn't seem to work. So what made you think that going to 30 milligrams, a tenth of the 300 milligrams, would work? What was your thinking on that?
Well, there were pilot studies, especially from Japan, looking at milk and egg, showing that you can be successful with smaller doses, but they didn't do head-to-head study. They didn't compare the high dose to the low dose.
Okay.
But, I think the thing that convinced me most was the fact that you sometimes, because we did the standard way to desensitize, and sometimes you get stuck. And with case reports that we've seen, you get stuck for a year and then suddenly things get better and they tolerate higher doses. So myself and Dr. Apton, Julia Apton, which is the first author, we discussed that and we said, well, for most of these kids, they don't want to eat peanuts as much as they want. They just want to protect themselves from accidental reactions.
Right.
And for that, a smaller dose that it will be likely associated with less side effect probably will be enough for these kids. And will be associated probably also with higher adherence. This is something that we need to assess in the future. But because it's a smaller dose, less aversion, easier to take every day, but still effective in protecting them against accidental reactions, because we need to remember a lot of teenagers, they don't want to eat Reese cups. They don't want to eat, jars of peanut butter. They just want to be able to enjoy a hockey game. Right, exactly.
They want to have a normal life.
Yes, exactly. Yes.
Yeah.
Yes.
What did I ask you? One of the things that you're aware of too, and I'm aware, it's rare, but it still happens, is something called eosinophilic esophagitis, where going even through the desensitization or eating the peanuts, they develop that eosinophilic sort of allergic inflammation, which is not good. I mean, they could get, tightness in their esophagus. Have you seen that, and do you think going at this lower dose, you'll be able to avoid that? Did you see any cases of that in the study?
So in our lower dose, I didn't see that. We didn't find patients that developed EOE, but we had a relatively lower sample size, like around 17 kids between 15 and 17. So we need larger studies to assess that, because the incidence of EOE or eosinophilic esophagitis in patients that go through desensitization is about only 5% and less. Now, it's very interesting with EOE, because it's not IgE-mediated process, unlike the life-threatening food allergy. And this has evolved as well, because I had parents whose child developed EOE. I had a few mainly with milk. And the parent told me, I don't care about the EOE. I know it's problem swallowing. I know about the scar that might develop in the future, but I'm more afraid that my child will die after having accidental exposure to milk.
Right, so that's where the risk-benefit has
exactly,
to
yeah.
play.
So now it's a shared decision. So in the past, we would stop and things will resolve.
Yeah.
Now, rather than stop, we discuss it with parents, and sometimes we say, okay, let's give him a little bit of proton pump inhibitors like Prevacid and reduce the dose and see what's happening with the EOE. And if the parent is very committed, not necessarily stop the OIT.
If you've been following the podcast, you may know I practice holistic functional medicine and immunology. In fact, at Mitchell Medical Group, we've been treating chronic fatigue patients for 3 decades. It's critical in this work to have a trusted pharmacy that can compound medications for our sensitive patients' needs. ITC Pharmacy has been our go-to pharmacy the entire time. They can make medications ranging from thyroid hormones to dye-free medications for all of our highly sensitive, even allergic patients. If you or your holistic doctor are looking for these very specific patient medications, you can contact ITC at 888-349-5453. They have licenses throughout the country and can have medications delivered right to your doorsteps. My patients have been so pleased with their service, and you will be too.
Yeah, I have a good idea if you want something
well.
on that too. That is interesting.
Yeah.
So I want to ask you, you may not have as much experience with this, only because very few doctors are doing it. I have been doing sublingual allergy immunotherapy for almost 25 years. I started with environmental allergies. I actually learned through somebody that had been training with the doctors in Europe, in France, and in Italy, Dr. Walter Conica, who's really an amazing guy. So I was doing that for 25 years. And then I finally said, okay, seeing the OIT work, and then also seeing the work by Dr. Edward Kim, who was originally at Duke and now is at UNC Medical, where he was showing that doing little sublingual drops under the tongue at much lower doses than the OIT, Dr. Kim was getting quite good results. He was getting like 60, 70% of these kids sometimes in the studies were able to tolerate up to 6 or 7 peanuts. And again, what I've been trying to do in my own private practice, because I'm not really a researcher, was like, give these kids enough protection so they can go to a party or a restaurant and not have to worry about it. They got to whip out their EpiPen and, or now today the Neffy, because they have a severe reaction. What's interesting is Dr. Kim, as you may know, in his studies, he would get up to 2 to 4 milligrams, which again, very low dose, even lower than what you did in the OIT, but again, was getting this really good effect. And then the patients could continue with just drops. I was just curious if anybody in Canada or yourself have been looking at that, or do you know, again, I find it easy for the patients because they're just doing like, it's almost like a medicine, like they're doing a little drops, like an eye drop under their tongue. And yet, and again, my goal is not to get them eating peanut butter and jelly sandwiches. It's to get them so they don't go into anaphylaxis from a dangerous smoke. And I'm dealing with, you know, a lot of people in their 20s, 30s, and some children. So just I'm interested in your thoughts on any of that.
Yeah, so I think in a way it's very similar to the low dose, because when you give sublingual, the dose that it actually absorbs is probably much lower than the dose when we eat, and it's similar to what we get with a lower dose. And we know that it works. There was a study, I think it was Woods, with egg sublingual showing that it works, and there are now studies exploring peanut. So we know that it works. I mean, the reason that we went not necessarily to sublingual, but to eating the peanut is because, you know, Canada, we are very limited in our resources financially. So patients will not pay privately to do OIT. So we need to be very resourceful in the way we make it safer. So that's why we went to a relatively easy way to desensitize through eating a very small dose of peanut.
Well, do you give them as the powder? Is that what you do? You know?
Yeah, exactly. We create a powder, and then if this was with placebo, so we encapsulated it so they won't know whether it's a placebo or the peanut itself, and they won't feel the taste because it was a placebo-controlled trial. But basically, yes, we just crush the peanut and we go to that small amount. And that's a protein amount, right? So,
you know, it's interesting. I don't know. It probably is available in Canada, and you would think it'd be cheaper. But, you know, we have, I don't use it, but here in the United States, we have something called Palforzia. And they go to very high dose, but it's very expensive. I think it's like $750 a month.
Exactly. Yeah.
And
so we cannot
peanut
afford
protein. You know?
Yeah, we can't afford it in Canada. So we go, and also when I do it in my private clinic, it's still OHIP or RAMQ, I use the sources that you can find easily in grocery stores. So, for example, for cash, I use cashew milk.
Right. Yes, I've heard people do that.
Yeah,
right.
Exactly. Very easy. Yeah.
Right.
Yes, exactly. And now with that new trend of, you know, healthy food, it's very easy to get milk for almost everything. So you have sesame milk, you have walnut milk, you have hazelnut milk. So with the milk, it's easy because you can get to very small amounts with small volume.
Right. Yeah.
You don't need to buy specific scales. You don't need to that.
Right.
You know, it's very, very practical.
That makes sense. Yeah, and again, one of the things I like about the sublingual, because again, I have patients I'm doing peanut or milk, but I have sometimes people that have like 4 tree nuts that they're very highly allergic to. So I'm able to mix it all into the same drops. And since it's a gentle desensitization, I tend to, knock wood, have very few reactions. And we're going to get to it after. I've been following these patients on BAT testing, basophil activation testing, and seeing some really good results. My other question for you too is the anti-IgE injection like Xolair. Do you find, you know, I know it's expensive. It's expensive here too. Do you find that it has a place? Again, if you and do you also would you consider it? I've been using some patients for a few months while I'm starting the desensitization if I think they're highly allergic. What's your strategy, or how do you use that with your patients?
So again, we're more limited financially.
Okay.
So Xolair or
Canada lets everything for free. Socialistic
for
medicine,
free,
right?
Yeah, for free for no one probably. Yeah, so basically, omalizumab will not be approved in Canada as it will be only off-label for food allergy. So the thing about omalizumab, yes, it's very effective. It blocks IgE, but it's not a disease modifier. So it can help you reduce side effects when you do OIT, but long-term, it's not the holy grail here, right? It does not change.
Because you lose it once you, like I tell patients, I try to use it. I try to make the military example. It's like having like airplane support while the ground troops are going through, meaning that, you know, that you're protected while you're being desensitized. You know, again, I'm dealing with adults who have anaphylaxis to these foods, so I want to sleep a little better while I'm desensitizing them. So sometimes if we could get it approved, because it has been approved now for food allergies in the United States.
Yeah, and I think that's a bit misleading because I had patients that were on omalizumab and did OIT, and once they stopped omalizumab, they started to have these severe reactions to the food, and they got discouraged. So I see more, if I being very practical, the role of omalizumab, I hope, in Canada, it will get at least in a way that will enable protection for a short period of time. For example, a teenager that goes to, wants to go to Asia, and, the parents are frightened and the child is concerned that there's not high awareness of peanut allergy there, and the likelihood of even a reaction is very high. So
That's right. That's
say,
a great example.
Yeah,
great example.
I would say
Especially
this is a
when you
great
go to
way to use
Asian countries where they use a lot of nuts and that kind of stuff. That's very dangerous.
Yeah.
All right, but let me just say, let's say the prime minister's son who's like 6 years old came to you and they say, Dr. Ben-Shoshan, I want the best treatment. And my son is allergic to peanuts, walnuts, cashews. What would you do? You have a lot of pressure on you right now.
That's fine. 6 years old is still fine. I'm doing it in my regular clinic, the desensitization for peanut, that it still works. And I can tell you that if it fails, we still have that program at the Children's Hospital in Montreal, and we'll be happy to have him on that program. We have actually different programs now. We look at both low doses and the incorporation of baked goods or processed foods that contains the food to see which one works the best and is the safest. So we have many options for him. And for cashew pistachio, usually I tell them, once we work on one, it usually helps for the other because cashew and pistachio cross-react. So my personal experience that when I desensitize for cashew and I get to the high dose of cashew, just give them pistachio in a supervised visit. High dose, I don't start from the beginning. And I can say that I never had somebody reacting to pistachio that was desensitized to cashew. Same thing for walnut and pecan. So you can have some shortcuts there. If you remember,
that's a great segue to what I want to talk. I'm going to switch a little bit from treatment, which is obviously very important, but I think we've covered all the key ground. I'd like to talk to you about food allergy testing. I like to be on the cutting edge of things, and I don't know, it just sort of dismays me to see allergists using older technology. The allergy skin tests have been around literally for 100 years. In the United States. Actually, the clinic where I trained was one of the original places where they did allergy skin testing. And it's still done a lot. Now, I don't do it anymore for a few reasons. I feel blood testing is more precise. It's safer. It actually even gives me a level of how allergic they are. I mean, because again, you can look at a skin test and say, oh, look, there's a big reaction. But this is more, to me, definitive and specific. I was just curious what you think about, because again, here it's a lot of political stuff too. The allergists are very protective of their turf. Do you use a lot of blood testing? Do you still do a lot of skin testing in the clinics?
So I think it all depends on the context here. So when you speak about skin tests, that's the most easily accessible confirmatory test that we have here. And it's much less expensive. In Canada, it costs much more to do an IgE test, especially component testing. So, and also it's important to do the skin test in the context of history. So I don't do skin tests for patients that come to me and said, I'm afraid that my child has peanut allergy.
Well, right. Well, that's what I always found. I felt it was very nonsensical. Like, a kid comes to you, I've had an anaphylactic reaction to peanut. Oh, we're going to skin test you to peanut. They could have an anaphylactic reaction. I mean, it's rare, but they could have anaphylaxis from the skin test. Whereas the blood test will tell you the specific proteins. It'll tell you how high, to me,
So what I mean is that when they never had a history of reaction.
I understand, right? It's unclear.
Like naive, peanut naive, for example, and they want to do a skin test. I won't do that because it's like shooting my own leg. There was a study by Copling and Jackie in practice that they've shown that about more than 50% of them are false positive. Same thing for the IgE.
Yeah, but also you can tell also, as you know, with component testing, I was going to mention this, let's say if somebody, like if you did a skin test of peanut on a child, for whatever reason, random testing, and it was like highly positive, the mother says, I don't think he has a problem with peanut. It turns out he's allergic to grass pollen, which cross-reacts. But a blood test, component testing, will pick that apart.
Yeah, so we
also have a lot of very fancy lawyers in New York and other parts of the United States. I don't know about in Canada. I don't want to get sued.
Yeah. So what I do, and that's my personal approach, because again, IgE are expensive here, especially component testing, and not always approved, is when I have a doubt, I just challenge them immediately in the clinic. So then I have my 100% answer. So I think the parents and the child are happier because it's not the doubt. Maybe I was overdiagnosed by doing an IgE or a skin test, and maybe I don't have an allergy. And also it's a function of time, because if you send them to do an IgE or skin can take time till you get the results. So now I do the challenge, and I know exactly immediately whether they react or not. And at the same day or the day after,
I understand that.
can
No, I
start the
know.
immunotherapy.
Yeah. We
I
get
do the
it pretty quickly
desensitization.
here. I get it within a few days.
Yeah.
So
Yeah.
that's kind of interesting.
Yeah.
So let me ask you, and because I've been following this very carefully. Yeah, I tend to do these very fancy and sometimes unfortunately expensive tests because I always want my patients treated how I would want to be treated.
Yeah.
And one of the things that I've been really following this carefully, and you do it in your study, is the basophil activation tests and the IgG4 testing, which I get from my patients. Because, I'm sure you get this too. The big question I always get from my patients for years is, well, how do I know I'm protected? And I know you can do challenges, which are also very hair-raising, because sometimes kids don't pass the challenge and they have a bad reaction. And I think the holy grail has been to try to find what are the testing that indicates what we call immune tolerance. Now, I've been doing the basophil activation testing. It's very tricky to read, but I've been seeing with my sublingual patients that certain parameters are going down. I was just curious in the study, do you have a lot of confidence in those tests? I mean, you obviously chose them, as ways to assess. I mean, I forgot at the end, did you challenge the patients?
Yeah.
You did. You challenged them.
We
and also
them,
you looked at the blood testing. Did it all match up? I think you mentioned that,
exactly.
Right?
Yeah. So it's like biomarkers, and they help you feel, that it's not only that the clinical work is successful, it's also the biomarkers that change. And it's actually the balance between IgE, specific IgE, and IgG4. And you see clearly that the IgG4 goes up. And that's also a point that I think is very important for our audience to understand, that all these companies that do IgG for foods, they're not helping you, because IgG means that you were exposed to the food.
Exactly. I know. We see that in the United States. People spend a lot of money but doctors don't know what they're doing. Usually they're not allergy doctors. They order IgG4 and it comes back, I'm allergic to cauliflower.
No, you're protected, actually. Yeah, exactly. So that was something that was
But you
important
feel,
for me
I know you mentioned this
emphasize.
in the paper, because I think you said something to the effect of the IgE maybe changes a little. We know that doesn't change a lot, but it's the IgG4 that goes up a little bit. And that you pick out. So it's really the ratio.
Yeah, exactly. It's the balance between the two. Yeah.
To all my listeners of this podcast, you probably know I have a lot of experience in diagnosing and treating mold-related illness. What you might not know is that not all mold testing laboratories are the same. In the past decade of diagnosing mold-related illness, I have used exclusively real-time labs urine mycotoxin testing. It's a spot urine sample that accurately confirms my patient's symptoms as they relate to the mold exposure in their home. Now, there are other labs that do urine mycotoxin testing, but I have found from my own experience that they are not as accurate and reliable as the real-time tests. So, if you suspect you have a mold-related illness and go for testing with your doctor, ask them specifically that you want the real-time urine mycotoxin test. And you can say that you heard from Dr. Mitchell, it's the one that he trusts the most. What do you think about the new nasal epinephrine spray, Neffy? Have you used it all with patients, or?
Well, it was not approved yet in Canada, so I didn't use it yet. Again,
it's not approved in Canada yet?
No, it will be approved probably in the spring of 2026.
Oh, wow. Okay.
Yeah, so we are behind you guys.
Patients, and I'm sure you're probably familiar with the literature and everything, and I've been prescribing it, is that, first of all, the nose and the sublingual area, as I do drops, is a very good area to get medicine. It doesn't mean you have to be injected. And the analogy that I make for my patients when they ask me, well, is it as good as the shot? And I said, for years, many years ago, when I trained in the hospital in internal medicine, we'd have people come in with overdoses, and we used the Narcan injection to reverse that. And Narcan as a spray, it's actually the same exact device, has been used now for years so that anybody could hopefully reverse an overdose on somebody. You don't have to be skilled to giving an injection. So, and I thought this was a great thing for kids because, a lot of them are understandably not excited to give themselves an injection if they have to.
Yep. Yeah, so it seems good. I mean, the studies are good when you compare the PK studies. They are very similar and comparable between the Neffy and the injectable epinephrine. It seems that EpiPen performs a bit better than Neffy regarding the dynamics of, but certainly they're comparable. And Neffy seems to be superior to the in pre-filled syringe that we do sometimes. So I think that it's a great option. I think we'll need more study to see how it really operates in real life.
Real life, yeah. When
Exactly,
more thousands of people use it.
Yes, exactly, yeah.
Yeah.
Yes,
like
for now we have only case series, yeah. But it's good to have another option, something that is also very compact and easy to carry, especially for teenagers that are not feeling very comfortable with these bulky EpiPens everywhere, or epinephrine auto-injectors. So competition is always good. Another option is always good, especially a strategy that does not use the same administration mechanism is always good. So
I think I've told patients this, I've told listeners this before. When my son was growing up, his best friend had severe peanut and tree nut allergies, and he turned out to be, he was a terrific kid. But I could see how it really impacted his life, because he had to go with his fanny pack with the EpiPen everywhere. And a lot of times, like some of his other friends, their parents didn't really want him sleeping over. They, like his mom used to be thrilled when he stayed over my house because they go, we got two doctors. My wife's a doctor also. We got the whole team on call there.
Yeah.
And I think that now with the Neffy, with the nasal spray, that's going to really take down, the fear factor. With this.
Yeah.
Let me ask you something else too, just to kind of come full circle as we're kind of closing up. People have asked me, I have my thoughts. I want to hear yours. They say, why are food allergies so common today, maybe than ever before? I'll give you my opinion in a second, but I'd like to hear what your thoughts are.
So again, as we said, the food allergy prevalence increased over a decade. So you won't expect genetics to change so fast. So it should be related to things in the environment. So either factors in the environment or lifestyle. And both are implicated in different studies. So lifestyle, the age of introduction, and major factor. I mean, the fact that you introduce early won't eliminate completely peanut allergy, but it will certainly protect you at least 7 times more if you are not only introducing early, but continuing the introduction. Right? Because one of the things that I want to mention is some parents, give it at the age of 5 months and then stop and then give it again at the age of 1 year and say, oh, I'm so surprised he got, anaphylactic reaction, but I gave it at 4 months. It's not only giving it,
no, you have
it's
to
continuing
continue.
and give it. Exactly.
Yeah.
You need to incorporate it in your diet regularly.
Right.
Exactly. And then factors in the environment. So many studies now suggest that the way we introduce things into our life, for example, there was a study about a rinse aid that impacts and disturbs the tight junction in our skin.
I'm sorry, what was that?
A rinse aid, a rinse like a dishwasher substance.
Oh, right.
Yeah. So that factor or that substance have been shown to impair the tight junction in the skin.
Yes, I know. I remember reading that saying, "Oh my God!" It's like modern conveniences are having an impact. What I thought from reading our literature and really believing it, I think it's also a huge microbiome issue. I think that unfortunately, so many of the young infants and children are given antibiotics, which change their microbiome and unfortunately seems to tilt it in an allergic way. And the other thing is that so many of the hygiene products, the soaps and shampoos, are now sometimes containing tree nuts. And people forget one of the easiest ways to sensitize someone is through the skin. And then when you take something orally, you get an allergic reaction.
Exactly. So that's the hypothesis, again, led by Gidon Lack. It's the dual skin hypothesis. So introducing small amount by the mouth at early age is good. Right. Introducing by the skin, especially with creams, especially in impaired skin like eczema.
Yeah.
I mean, all these people that COVID, they are doing very nice thing by introducing, trendy creams that contain soy, for example.
No, it's causing problems.
Yeah, exactly. Yeah.
Well, Dr. Ben-Shoshan, is there anything else you want to mention? Because I've had such a great time discussing this with you, and I loved your articles. Anything else do you think we didn't cover?
Well, I think it's, thank you, first of all, for having me. I think it's a very exciting field. Things are changing so rapidly. I was just now in a conference speaking about mRNA vaccines to prevent peanut allergy. I think we're so far away from this kind of intervention. But I think, as Da Vinci said, simplicity is the ultimate sophistication. We need to think about the simple thing that we can do in life, like early introduction, using smaller amount to desensitize in order to benefit our patient. And that's, I think, will be our priority.
Yes, I think that's great advice. So for our listeners, if you have a child with severe food allergies, there are options today. Talk to your doctor. get the latest information. You could really make a huge difference in their life and in your life. So thank you so much.
Thank you.
Moshe, thank you so much.